Yeah. Box. Hi everyone, we're about to get started. Half an hour, one question, one follow-up. Dr. Williams and Dr. Yaffe will begin with brief remarks.
Hey, good afternoon. And here we are on Monday. This is the second week of, I said, the intense observation 2 week with a lot of need for precautions, stay at home, social distancing, physical distancing, whatever term you use. We understand that some on the weekend were less than vigilant in that way, and while the weather may be inviting a little bit, at least the rain kept some inside, and you need to stick at the task because we're going to compare some numbers here again today. And the issue, while for some it doesn't seem to be close at hand, it is close at hand, and we're trying to keep that message going clear, that by doing what you need to do, you can protect yourself, your family, and your loved ones, and especially those that are vulnerable that you know and connect with. So that's the overall arching message for today that we're going to look at. We're looking at increasing public health measures that you heard of over the weekend that we needed to do to continue to ramp up the need to be vigilant in this ongoing task that you have ahead of you. We started down this about 2 weeks ago with the March break session traveling being canceled, and we're now in our the second week of school closures, and we're going to continue that messaging going forward, and hopefully we might be able to see a bit better by the end of this week and the next week. Are we starting to bend the curve? And we hope to be able to give you some information in that regard, but it's still too early to say. So first, let's go to the daily numbers over to Dr. Yaffe, and with those counts. Thank you.
Thanks very much. So as those of you who have checked the Ministry of Health website would have noticed, we have updated it now to how we report COVID-19 cases using the daily epidemiological summary produced by Public Health Ontario. And this provides you with more provincial and regional data on confirmed cases, trends of cases since this outbreak began, geography, exposure, and severity information. So as of this morning, we have a total of 1,706 confirmed cases of COVID-19 reported in Ontario through the system we called IFIS, Integrated Public Health Information System. And that is the system that the local public health units use to input data on case and contact investigation. So that is where the information is coming from through Public Health Ontario. So 1,706 represents an increase of 351 more cases than reported yesterday. At the time of this morning's posting of the information, there were a total of 23 cases who unfortunately had passed away. We know that this is a very fluid situation, and the data we're presenting is a snapshot of time. However, we are aware of an additional 10 deaths that have happened, that have been reported through the local public health units, press releases or online since this morning. And that brings the total right now actually to 33 deaths that we're aware of, sadly. I'm pleased to note that of the 1,706 cases, 431 are now considered resolved. In terms of hospital information, from the critical care information system, we are aware of a total of 100 cases of confirmed COVID-19 patients who are in intensive care unit. And of those 161 are on ventilators. In terms of the laboratory testing, the labs now have done approximately 4,000 tests over the last 24-hour period. The backlog of tests is going down rapidly. At this point, as of this morning, it was about 5,650, and we expect that backlog to go down even further over the next couple of days. Thank you.
Thank you, Dr. Yaffe. And so you can see that while the number of positives is up, As we said before, that would not be surprising knowing we had the backlog. And if we look at that, the actual percent positivity hasn't changed substantially, but we still have more backlog to deal with. And so I was surprised that we didn't have numbers higher on the weekend. But this reflects some of that residual as we move into this week now. But you can still see there's a lot of activity. There's a lot of people coming through positive. And remember, this reflects back about 5 or 6 days ago. So one cannot be complacent in one's dealing with their need to be, again, vigilant on doing the social distancing and the physical distancing. And that's one reason why I did send a letter out emphasizing that to the public, trying to encourage you. That we are in this together, and while it may seem long for some people, I know it's a task to keep at it. The virus does that. It doesn't replicate and move among people that quickly. So we have these 14-day periods that I'm locking in on, and we're into the second week of this 14-day period, which by the time we finish by the weekend will be our 5th in our journey through this time here. So we need to stay the course. It's like a long session in sports analogy. We're into the 3rd and 4th quarter. We still have to keep going strong and not give up on that, and we can keep working and beat, I think, COVID-19, at least bend the curve, if not get it down even further. And we've already seen some early evidence of that as we've talked to our modeling individuals. So that is encouraging, but it's not enough yet. But we're still seeing the effects of those because they're delayed as well, and to see how well we're doing in that regard. But we've had some other measures of how well you're doing with public health measures. And for overall, I think Ontarians are doing quite well. There are some people who choose to be casual about it, and I would request them not to do so because you put yourself and others at risk of continuing the spread of the virus within the community potentially. And you need to think of more than just what you would like to do at that moment and your rationale for putting aside the social distancing and the physical distancing, and you need to be vigilant. Excuse me, as well. I want to talk about we did put in the order with the 5 public gatherings, or no more than 5. And that was felt necessary. I had a number of comments in from the public saying that only didn't make sense. We are trying to be still sensitive to some events, such as required funerals. And we did alter to that effect. And they can be convened at an event, not a public event. And besides that, we wanted to look at the over 70s. And we want to make sure that you did stay inside. Excuse me. Dry air. I may get you to take over. I gotta clear my throat, sorry. And we want you to stay inside and help others to help them out in that regard. So you need to stick at that task. I'm going to ask Barbara to talk about for a moment until I get my throat cleared. So if you want to talk about the aspect with long-term care homes.
Sure, thanks. You better drink some more water.
I do, thank you.
We always knew that the population in long-term care homes is a particularly vulnerable, high-risk population for serious illness, complications, and even death. So unfortunately, we are starting to see that play out in places like Pinecrest, in Haliburton, Kawartha, Pine Ridge, and the medical officer of health there has been working very closely with the facility and with us to try and increase the resources and increase the practices in place. But it is challenging. And we're also looking at perhaps strengthening information and advice for long-term care staff. We know this is a difficult situation. It's a challenging situation. And there's a lot of interest in making sure that everything is done as best as possible to keep those very highly vulnerable people as healthy and safe as possible, and their staff, who are extremely key to the situation.
Thank you. And with that, I'm going back to the 70-year-olds that are not in institutions, those over 70. And we know they're at high risk, and we're trying to identify those to give them support in that regard. And we want to encourage them, but we want to encourage the community, the family members, those who know those ones. Because if we really want them to stay inside and not go for those early sales at stores, etc., then we have to do that for them. We have to go and make sure they have what they need so they don't feel forced or pressured to go out of the house in that. And keep connecting with social media, because sometimes it's a lonely spot. And I find more and more evidence of people maximizing that kind of connectivity, and it's great to see that. And I encourage you to be even more creative in that regard and to keep doing that as we go into this extra week in that regard. So I think, as Dr. Yaffe's alluded to, our concern ongoing with our long-term care residents as we seek to surround them with as much protection as possible, asking family members and visitors to deal with the issue of staying out and not visiting, but we're trying to look at ways to maximize social media there, that virtual visiting is something that can be done, and we want to make sure there's enough resources in all levels, including personal protective equipment and testing. We've modified some of our methods of carrying out investigations with our public health partners and working in partnership with the long-term care facility management of how to undertake investigating very early, very quickly, any suspected COVID-19 cases in those settings, and trying to move as rapidly as we can that to ensure that, and including we're adding in retirement homes as well. And that's another area we want to work at and use as much extra energy and effort as we can. We are notified that by the Canadian Border Security that the number of travelers coming across into Ontario is continually dropping, as would be expected. And we're still dealing with some coming across, and how the federal quarantine order works and how we're supposed to work with our federal counterparts to ensure that all those individuals coming across, as required by the order, do go into mandatory isolation for the 14-day period. But again, we want to make sure that if they're going to do that, that we would build in some means that they would be able to get their needs met, and those things that are essential, that they would not have to violate the order in order to get it. So we need to help them to help us, and help us collectively to do what we can do to bend the curve. And I feel we can do that, and we are working at it. But this is the time to really bear down and stick with the task or this week ahead, because as I said, you can see the numbers jumped up today, some of it due to backlog, but we're still watching closely to see if they will escalate even more. And that is what we're monitoring, as our peers across the country are doing in their respective jurisdictions. So with that, we'll take questions from the media.
Okay, we'll go ahead with the first question.
Your first question comes from John McGrath with TV Ontario. Please go ahead.
Hello. I'm watching a debate sort of unfold both in the press and in social media about whether or not people should be wearing masks. And I think people generally understand that they shouldn't be, going out and buying dozens of surgical masks or masks from the hardware store. But I'm wondering if there's been any thought to changing the public health guidance to guide people to at least adopting some kind of face coverings at this point.
So our position all along is that I would prefer that people kept the 2 meters as compared to the mask. I've seen some people with masks who tend to be able to think they can ignore that, especially some of them are some are loose fitting, some are down in front of their nose, and they're continuing to lift them and taking them off. So I don't think that at all covers the benefit of the 6 feet or the 2 meter. And so I would continue to push that aspect. We've asked that some who feel they have to be in close contact for essential services would want to consider wearing a surgical mask if they want to, in that benefit there. For the general public, by doing your proper social distancing, you can avoid those type of situations, and I would hope you do, especially if you stay home as you're supposed to stay home and protect yourself in that regard. So, and I see some people like in a vehicle driving with a mask on. I'm not sure who they're protecting in that situation. And I'm talking about taxi drivers, I'm talking about private citizens. So I think the use of masks and that kind of thing, if it's using up your valuable personal protective equipment and supplies and orders that our healthcare providers and the other essential services require to carry out the duties and responsibilities, I would not be supportive of that. I think some people can do some other things in that area, but I would still prefer the social distancing, the physical distancing, as compared to a number of people wearing masks and standing in clumps and large groups together. I can't support that at all. I don't understand the basis of that. So I think the debate will continue. I think it's using the right thing at the right time in the right way and doing the right procedure in the right way and not putting yourself into a situation where you're compromising your, as some people like the term, your bubble or your area and zone of protection. So I think, well, it's not a debate. I think it's more of the aspect of what are you doing and what are you trying to attempt to do in that situation where you supposedly can't do your proper responsibility with physical and social distancing.
If I could just add to that, we are continually working with Public Health Ontario and reviewing the most current scientific evidence on transmission and modes of prevention and what the most appropriate interventions are. So I agree fully with what Dr. Williams said. The only exception would be if somebody's symptomatic and they're being sent to an assessment center or a hospital, they should put on a mask or cover their face, their mouth and nose so they don't transmit it to anyone else. But otherwise, if you're wearing a mask, it almost gives you a false sense of security. People tend to touch it a lot and then easily transmit infection to themselves that way, which is obviously not what they want.
I'm sorry, John, but I think because we have a long list of people today, we're going to stick to one question to make sure everybody has a turn.
For my colleague.
Okay. All right, we're going to move forward.
Your next question comes from Travis Daharaj with Global News. Please go ahead.
Hi there, Dr. Williams. The Premier was asked this question by a number of my colleagues earlier today about possible mandatory stay-at-home order, considering we've seen seniors, firefighters, police officers, grocery store employees, frontline healthcare workers, construction workers, folks of all stripes come down with COVID-19, and this death toll continues to get worse. And every time he answered the question about putting more measures in place, he said that he is deferring to you for your advice. So at what point do you advise the Premier that more measures need to be put into place to prevent more deaths from happening in Ontario?
Well, that's always on our mind as we're looking at to see what are the essential services that allow Ontarians and the large general population to stay at home, to keep up their social distancing, etc. If there are some essential things they need, even with those things in place, they'll usually they may take steps to go and get them anyway. So we want to try and facilitate that as much as possible. If we felt that there was aspects related in there, as we continue to monitor, for example, our healthcare workers, our first responders, to see if there are infections, are they sourced from internally, are they sourced from still travel related or other things like that. So we want to watch that and observe to see if there are risk situations that are evolving in various essential or work positions that would not be acceptable at this time. So we're not ignoring the issue. We want to say, can they undertake those jobs and those essential services and still maintain the aspects of social and physical distancing? If it doesn't seem possible, and if we do get evidence of some infections, and of course you can imagine why we say healthcare workers, because sometimes they're going to have to be in close proximity of people. That's why they wear personal protective equipment. That's why paramedics wear and others. And so we understand those situations. But the other ones that we are monitoring, if we're informed that there is a large risk and we see outbreaks and cases, then I'd have to advise the Premier differently, identifying each one of those if it was problematic.
Okay, we're moving to the next question.
Have the Doctor, why does Ontario have the lowest per capita testing of any province in the country?
Ontario has the most tests done of anyone. We're doing the most per day of the others, heading for that direction there. So it's numbers and per capita and rates and different aspects. All the PTs across, as we have our national meetings, are struggling with the issue of capacity in lab, so that where some had done quite a few, all of a sudden they find themselves in the same situation of having to ramp up their laboratory testing methodologies, trying to deal with that. So I don't think anyone has any, I would say, bragging rights in this regard. We're all doing our best to ramp up the testing and that, and we share each other's challenges because we deal with the same supply sources and other things. So we're trying to do this on a pan-Canadian basis, as well as serving the needs of our respective provinces and territories.
Okay, moving on. Next question.
Your next question comes from Allison Jones, Canadian Press. Please go ahead.
Hi, Dr. Yaffe, you had mentioned off the top that there have been 10 more deaths for now a total of 33. Is there any other information you can give us about those 10 deaths, be it health units, ages, whether they were in long-term care homes?
Okay, well, I have bits and pieces of information, to be honest. And what I can tell you, and it's not complete because these were coming in through the day, and we will have more complete information for tomorrow morning, but I will tell you what we do know, which is there was another death in Halliburton. We're not sure if it's related to the outbreak or not. 2 additional deaths in Lambton, who are in their 70s or 80s. 1 in Haldimand, Norfolk, and 1 in Huron, Perth in their 60s. And that is the extent of the information I have on those at this point, which is absolutely incomplete, of course.
Okay.
Thank you.
Thanks. Next question.
Your next question comes from Jamie Gertflum with CP24. Please go ahead.
Thank you very much. This question is for Dr. Williams. Doctor, in your statement that you issued earlier today just on the guidelines surrounding COVID-19, I couldn't help but notice in your recommendations for leaving the house, you had 5 recommendations, which basically included accessing healthcare services, shopping for groceries, picking up medication, walking pets when required, and supporting vulnerable community members. I couldn't help but notice that just leaving the house for some exercise or going for a bike ride was left off that list, and I was just wondering if you can further clarify if that was done intentionally because from what you're witnessing of a lot of people disobeying the guidelines about social distancing and congregating in large groups. And the second part is, does that indicate that you're inching closer, or are you inching closer to recommending a full-scale lockdown of the province so that we can help flatten this curve?
So, yeah, the main ones we want to mention are the essential activities, the exercise one. We have seen some people, especially on the weekend, going out to large areas. And it's like if you know it's going to be a busy area, and you know when it's going to be busy, you don't go there. And you stay away from those areas there. I'm not discouraging someone from going out for their early morning jog if they feel they're going to do it around the area. We still like people to stay at home as best as possible. If it means that you're going to be out in large numbers and into congregations where you can no longer maintain social distancing, then that's a problem. And we didn't say that's an essential function. You can do your own workouts in the house, etc., in that regard. So these ones list the things that I was saying, the 5 of them that are important for people for meeting needs and helping those who need to be assisted, as I said, with the community needs. So I think we're going to say for this time here that if you can't do it in a safe way, then you should stay home from your exercise and walking. But again, if you can do it in a way that's off hours, not going to busy places, in that kind of aspect there, then you need to do that. So do your social distancing. If you can't, stay at home.
Okay, moving on. Next question.
Your next question comes from Rob Ferguson with the Toronto Star. Please go ahead.
Hello, doctors. Just to follow up on Jamie's question there. So I take it that answer was for... We lost you.
I'm sorry, Rob, you'll have to speak up. We can't hear you.
Okay, let's move to the next call and we'll come back if he's able.
Okay, your next question comes from Mike Crawley with CBC News. Please go ahead. Mike, please go ahead. If you have us on mute, please unmute your phone.
Hi, Mike, we can't hear you at all.
Mike, if you have us on a headset, please lift your handset.
Mike, can you hear us? Okay, I think we should move forward. Next question.
Okay, your next question comes from Allison Martell with Reuters. Please go ahead.
Thank you. Is whatever workaround to boosted testing levels over the last few days a temporary fix or a permanent solution to the slowdown that we've seen in Ontario over the last week or so?
I just missed the start of that with the work.
Sorry, I was saying, is whatever workaround that boosted testing levels over the last few days a temporary fix or a permanent fix?
Oh, with the laboratory testing, it's a permanent fix. We were hoping to. We did move up a little bit over 5,000 on the weekend. We did 4,000 last night, and then we moved the backlog down. We hope to move that up from not only 5,000 to 10,000 if we can, and then get rid of the backlog totally. So it's meant to be a permanent fix.
Okay. Do you anticipate expanding who you're testing at all, given that?
I think if we have all our priority testing done and doing everybody back to where we were with a 24 to 36 hour turnaround, then we could contemplate doing some wider type of survey, much like we're doing with our surveillance tool. We could start to do that kind of aspect as well. Plus, with the changing directions, we may be changing some definitions to get a wider part of the population involved in that. But we want to get first our priority populations done, our people who are symptomatic done, healthcare workers, as well as first responders and those aspects there, and other ones related to remote and situations like long-term care facilities, which we've already talked about as a big priority, and as well any remote communities such as our First Nation or Indigenous population communities.
Okay, next question.
Your next question comes from Miranda Anthistle with Global News. Please go ahead.
Hi, doctors. Thank you for taking my question. We're hearing from some long-term care workers that they're being forbidden from wearing masks on shift. So in the wake of this Bobcaygeon nursing home outbreak, what exactly is the protocol?
You're right.
I think the protocol is actually under review at this point. But if they're working in a facility that's in an outbreak, they definitely should be wearing a surgical mask with all patients and more full protective equipment, eye shield, gown, gloves with patients who may be infected with COVID-19. If they're not working in an outbreak facility, then I think that's where the recommendations may be changing at this point. I'm not really aware of the details. But, obviously this is something that is extremely important. We need really strong screening of staff coming in, no visitors, only in the most extreme circumstances, and extremely, scrupulous cleaning. And so I think the personal protective equipment for staff is just one of the many things that needs to be done in these kinds of facilities.
Okay, next question.
Your next question comes from Moahim with Vista Radio. Please go ahead.
Hi, thank you for taking the question. So, So as reported first in the Toronto Star, out of 920,000 visits to Ontario's self-assessment website by midnight March 27th, there were about 100,000 that were directed to seek immediate assistance. So is this some sort of technical glitch, or does this resemble the number that we should be expecting here in Ontario?
So to be clear, you're talking about the self-assessment tool?
Yes, I am.
Right, and so we have been really pleased the number of people who have been accessing that site with 273,000 at sometimes coming through. And so you're asking specifically, because there's different categories. We have the ones that are not really that ill or just asking information. We have the ones that were self-assessed to self-isolate. We have ones that where the self-assessment would be unlikely related to COVID-19. We have other ones that wanted to self-assessment to get to call a nurse and referred over, and other ones that were felt to be necessary to go right to either emergency department or call 911. So each has its category. The ones that mostly were moved to be self-isolated was around about just under 25%.
Okay, next question.
Okay.
Your next question comes from Catherine Burlott with Radio Canada. Please go ahead.
Hi, doctors. Thanks for taking the question. I was just wondering, the new way that the numbers are reported on the provincial website, it talks about men and women cases, and I'm just wondering how that would be, that could be relevant to understanding how the pandemic is evolving. And can you just give a little bit more information about why you've changed the way that numbers are published, and also how we can better understand how things are going?
Sure. Up till today, previously, we've been reporting based on laboratory numbers. Of course, those are important numbers, but they don't give you the whole picture of how many people, how did people get it? Did they get it through travel? Did they get it through contact? Who were the people who got it? So when we look at how do we determine what's going on with a trend in a disease, we always look at person, place, and time. So we need to know what age group, how many people in each age group are affected. Is it affecting males more than females, which apparently seems to be the pattern? What are the characteristics, as much as we can determine, of who is more seriously affected? And those kinds of, and the geography and those kinds of pieces of information and data help us direct how to prevent further cases and how to target treatment as well, or care, and plan things. So these are very important pieces of information that we are getting through the investigations by the public health units that they put into this database called IFIS that I mentioned. So as that data is getting more and more rich, that is what we're now using for posting information. So it gives you better information for the public. It gives us better information for planning and delivery of services.
Next question.
Comes from Lisa Hefner with CHCH News. Please go ahead.
Hi, doctors. I have a question. We saw a story on social media this morning that looked like an Alberta company shipping the supplies for an 8,000 square foot temporary hospital to be constructed in Burlington, Ontario. Can you confirm, is that something the province is doing right now? Or are we about to construct a bunch of temporary hospitals?
I haven't heard that. We are looking at other currently existing facilities to use in that side. We haven't gone over to temporary facilities that I know of officially in that. So I can't say I know anything about that one that's on social media related to Burlington.
Okay, thank you. Next question.
Your next question comes from Laura Stone with the Globe and Mail. Please go ahead.
Hi, doctors. I'm just wondering, Dr. Yaffe, you mentioned in your opening remarks about additional measures coming for long-term care homes. Can you be a bit more specific? What more can be done to prevent something similar to what we're seeing unfolding in Bobcaygeon today?
I think I passed that over to Dr. Yaffe while I was clearing my throat. So we've been looking at the challenge, and this is not just us, this is across Canada, of trying to understand how best to protect this vulnerable population, with the fact that a lot of them do not evidence a lot of symptoms early on, and to detect that as quickly as you can. So in the past, we had a protocol related to influenza, and where we would stop testing after we found 4, and we had plotted a group outbreak and linked them epidemiologically. Now we're saying we're going to go much quicker on that. As soon as you have a case, someone symptomatic, we're going to assume that it probably is an outbreak and it probably is COVID-19, to start doing your action right away, not waiting until you get your laboratory testing done. And there's a number of steps that we're asking the long-term care facilities to do. We're in bringing in more training. We have webinars planned for the staff there. We're looking at our regional resources, much like using in the past. We had the term we had called regional infection control networks. We still have some of those people, staff there, that were related to hospitals, but we can link over to our long-term care facilities, looking at how we can do an all-hands-on-deck approach. If you have a facility that is a possible outbreak, bring in what you need to do a number of things to help them. Look at their staffing, look at their structure, look at their case management, look at how their cleaning's done. All those aspects that sometimes by bringing in a team, you can help out in that acute situation and circumvent a larger outbreak, as we have seen in some facilities already in that regard. So we're really trying to ramp up a number of things in the long-term care facilities around screening, around staff, cohorting. If you have a large facility, can all the people stay on the same floor? Why, instead of wandering around, can they use smaller areas for eating so that if you do have an outbreak, you can wall it off fairly quickly, or cases of concern, and map that? Can the staff stay on the same floor? Can you have limited staff movement between different facilities? So all these things are being looked at intensively, and we hope to have some new directions out on that very shortly in consultation with the Minister and the Ministry of Long-Term Care.
Next question.
Oh, do I get a follow-up, or?
We were going to one question each for the interest of time, but if you have a quick question, then sure.
I just quickly, Dr. Williams, do you think will you be publicly posting online, as you do with the cases, where these outbreaks are happening in long-term care homes for families and others who are concerned about their loved ones in these homes?
So right now, the public health units in those areas, if they have an outbreak declared, usually are going public and making that notice aware of it. We get those and we correspond with them on that. And then sometimes where we like to have it done, if there is an outbreak in a facility, it should be a joint release from the management institution combined with the local public health unit, because they're trying to give advice and direction to the family and the members so they can be advised properly in a timely way. And then if they have follow-up questions about the details of what that means, they need to go to the organization, the management of the long-term care facility, as well as to the local health unit, to seek direction and advice of what they might, could, or should do in those circumstances. So it's a lot better if it's run at the local level in that way, so they can be handled, because a lot of the citizens are going there are from the local area.
Next question.
Your next question comes from Kate Allen with the Toronto Star. Go ahead.
Hi, you can hear me okay?
Yes?
Yes, we can. Please go ahead.
Okay, I have a question about IFAS. My understanding is that public health units are asked to report probable cases into IFAS as well as laboratory confirmed ones. And I'm wondering how many probable cases have been reported through IFAS so far, and will you start releasing that number or including it in the daily case counts going forward?
At this point, we're not including probable cases. We know that some public health units are entering them and some are not. And they're not as high priority as the confirmed cases. So as we move along, we'll have to see whether it makes sense, whether it's even feasible to include probable cases. There should not be too many probable cases. It depends. It's related to lab testing capacity. And as you hear, lab testing capacity is going up. So hopefully, really, we're dealing mostly with confirmed cases.
Okay, next question.
Your next question comes from Rob Ferguson with the Toronto Star. Please go ahead.
Okay, sorry about last time. Trying again here. Can you hear me?
Yes, we can, Rob.
All right, thank you. I'm wondering, given your directive today for people over 70 and those with underlying conditions and compromised immune systems, how much higher is the risk all of a sudden? And can the people in those conditions or situations, can they also go out for a walk if there's no one around, or do they really need just to stay in the house or, in their backyard?
So in that area that we have, and that's what we're trying to do now, I think you asked the last time about with cases and can we have some segmentation by ages. We've done that in our report now where we have 19 and under, and that's a certain small percentage. We have the 20 to 60, 40, and we'll probably have to divide that to smaller categories. That makes up the bulk, that's 77%, and we have the 65 and older, which is 20%. Yet in that 20% group of those ones there, they have the higher rate of hospitalization. They have the higher rate, unfortunately, of mortality in that group. And we know that the mortality changes and hospitalization, like if you take from over 80 versus over 70 or over 60, it goes up continually up there, so that The older you are, the more likely you are to have severe consequences from a COVID-19 infection. Add to the fact, if you build in other comorbidities, that escalates that. Now, you haven't got that breakdown for younger people, say between 40 and 60, who have comorbidities in the absence or in a younger age group in there. We know there is some increase, and we're looking at some data comparisons to see how large is that. But we're mostly concerned there is people who are definitely immunocompromised. For example, those who have either had post-transplant, post-cancer therapy, etc., that their immune systems are compromised due to their therapy and medication. So they have to be taken very extra precautions, as we would with any communicable disease outbreak.
Next question.
Your next question comes from Kenyon Wallace with the Toronto Star. Please go ahead.
Hi, I'm really sorry if you've already said this. I was having technical difficulties with my phone earlier. How many tests currently are being done every day as of now?
So, in the last 24 hours, the labs did approximately 4,000 tests, but this number is going to go up every day. And they're aiming to, by mid-April, to around almost 19,000 a day.
Okay, next question.
Forgive me if over the weekend, David Williams said 5,000.
On one day, they did put through 5,000, and then as the other labs come on board, they have to be quality checked in that regard. And also it blends the mix there when you're talking about tests versus, individuals tested versus samples. The more cases we get admitted to hospitals and to ICUs, each one of those has multiple samples put in, so that does reduce the number of individuals being tested. If you can understand, if there's like 60 or 100 people that are come into a hospital setting, each one of those may have 2 to 3 samples, and that would take up that kind of testing capacity in there and reduce the overall number. So it moves a bit like that, but we did bump over a little bit. We're just over around 4,000, and it looks like the external ones that we're adding on are quickly ramping up.
Next question.
Your next question comes from Mike Crowley with CBC News. Please go ahead.
Hi, doctors. I'm wondering about the intensive care unit suspected patients. Dr. Yaffe, you said, there really ought not to be so many probable cases out there. What's being done about prioritizing those cases? Why are there so many patients in hospital ICUs who are showing all the symptoms of COVID-19 but don't have their test results back yet?
So, yeah, thank you for asking that. And we've been asking the same question in there. I've been asking, what is your case definition in the hospital and in the ICU of a suspected case? Is it the same as ours out in the field? Yes or no? It seems to be right now anyone with respiratory distress is COVID-19 suspected than otherwise. It does puzzle me a bit because we are prioritizing those ones so that if they have a suspected one, we assume they are going to take the samples as quickly as possible, transport them as quickly as possible to one of our many now regional labs around, and we would like to turn that result around in 24 hours. So I am not sure why they're not moving those through to confirm or rule out as quickly as they can in that result, because we are certainly making testing a priority. And for us, to confirm has to have a positive test. If you have someone that you can't get any positive tests on and they continue to be negative and they're in respiratory distress and you need them in ICU or on a ventilator, there are other causes that we have all the time. And we ask them to tighten up their case definition of what do you mean by a suspected, rather than just it's a default when any case comes in these days. We like to make sure that is more firmed up and that they expedite the testing in so we can move it to the confirmed or rule it out as quickly as possible.
Okay, thank you. Next question.
Your final question comes from Lisa Zing with CBC. Please go ahead.
Hi there, doctors. My question is also about long-term care homes and testing. I spoke with some experts who say we should be testing everyone in long-term care homes as soon as one person tests positive and not just adhering to flu protocols. So is that something you guys are thinking about recommending?
So we move quickly to testing anyone who has any symptoms or concern to the long-term care staff, especially those that might be right around that person in the same area, and staff, if there's been a staff member who that staff member might have been in contact with. The challenge, of course, with long-term care residents is that because of their age or their conditions, they don't manifest some of the more overt or obvious signs of COVID-19 or the influenza-like illness. They may not mount much of a fever. They may not evidence much of a cough. They always have a cough sometimes. And so we're looking at more and more finer measures to say, can we detect it earlier and earlier? If we just went around and tested and say it had a negative test today, and then tomorrow there was another person, would we ignore that person? No, we'd have to go back and test them again. A negative yesterday doesn't mean they can't be having it today. So it may give us a sense of false security. So we're going to have to be very, I would say, very detective and careful the method of looking at those early signs. And we're having discussions with experts, geriatricians. How can we do that better? What are those even softer signs that maybe not so obvious that would indicate this person should be tested irregardless they don't evidence all the signs of COVID-19? So it's something we're driving at, and it's one of those challenges that COVID-19 presents to us.
Okay, thanks everyone.